And if there isn't, then we need to look at what our alternative solutions are going to be, so that, again, we can link someone to their home, even if we get the data late in the game, so late in December for a January 1st date. What we want to make sure is that we don't end up auto-assigning someone, a member, to another provider if the clinic home is indeed eventually going to get to us. So we've been doing a lot of mapping of that process. And in terms of once we get that information and they are assigned, we have an existing, robust process of onboarding our new members. And however, because of the influx of the high volume of members come January 1st, we are also developing a staffing plan to address what we anticipate will be some peak periods of high phone call volume and outreach that will be necessary. In terms of transitional care, so this speaks to, again, how are we going to plan around ensuring that there are transitions of care that are proactively planned for this population? What we hope to do is be able to utilize the LIHP program utilization data to basically mine the data, run various reports, whether it's by diagnosis code or other, claims codes, as well as using pharmacy data, to try to really take this population and proactively risk stratify them if possible, so that we can begin to put this population into different tiers, and we can have then implement strategies to address these various tiers. The idea is that we want to make sure that those that have the most complex needs immediately on January 1st, because they're currently in the middle of extensive care today, are identified, and we can reach out to them, as well as work with our clinic and provider partners to make sure they're aware of them and that there is a need to reach out. So that is an activity that we plan to do. Again, that will be dependent on us having the utilization data. Open authorizations, we also would like to explore working closely with our county partner as well as state partner on having reports generated of open authorizations. I know that the state is in the process of putting together its process as to how it will pass that information. From a plan perspective, what we definitely would like to see is we'd like to have a report of all the inpatients, for example, all those members that are in the middle of inpatient care come December 30th, 31st, that are going to be continuing to need care at an inpatient setting come January 1st. We'd like to get a list of all those patients that have really critical ancillary service requests that are in process. For example, if you have someone in the LIHP program that just became, who needed, for example, let's say oxygen, and let's say has an oxygen service provided in late December, we want to make sure that we flag those so that come January, that oxygen service isn't disrupted. And there's potential for outreach to our ancillary providers, so they're, again, aware of who these members are, and so that they're aware also of what to do to continue that service. The other area we want to focus on is engagement of special populations, specifically the Ryan White Clinic patients. So there are a pretty sizable group of patients in the LIHP program who are connected to services through Ryan White. Again, we want to make sure that the services that they've been receiving with their existing providers are continued and protected. Again, Department of Mental Health, we've started conversations and collaboration with the Department of Mental Health to again discuss how is it that we can plan together. The exchange of data between the Department of Mental Health and then the physical health care side is always a dilemma and a challenge given the different privacy laws of confidentiality. However, we want to still figure out a system to make sure that there's connections and people that are getting mental health services today can continue to get them. And then, of course, there's the homeless population, and we really are going to be relying on our county partners who have a significant background in working with the homeless population to develop strategies to connect with these folks. Let's see here. In terms of continuity of care protections, so as Sarah spoke earlier, there are, these members do have rights. As a health plan, we recognize they have rights. We have policies and procedures in place that reflect these rights. And we will again remind all our provider partners of those so that they're aware about how to go about ensuring that they do go through the process of providing continuity of care service. We are actually looking at some contractual strategies to make it easier for an IPA or medical group who receives a LIHP member, has them for the first time, to connect with the previous provider. So we're trying to figure out solutions to make that much easier. Let's see here. And in terms of continuity of care, kind of taking and learning from the SPD experience, and then the planning that we've been doing on duals, we recognize that there will be a need to have kind of an expertise, a resource team, if you will, internally to deal with these continuity of care issues and to basically flag them and report them so that we can make sure we follow up and understand what is occurring, and we know who to go to, what IPAs have continuity of care requests, check in with them to see if they've been following through with those, et cetera. Initial health assessment. So with the initial health assessment, given that the department has given guidance that initial health assessments will be required for those who switch primary care medical homes, but won't necessarily be required for those that continue to be with their current medical home. What we'd like to do is using the utilization data that we are able to obtain from our county and state partner. We'd like to again mine that data to identify those that have been receiving services through a primary care setting, to basically forecast those that have been in care and those that have not been in care. And that would be a way for us to be able to develop a strategy for outreach for those members that have never accessed services in a primary care setting and may have been receiving services but maybe solely through the ER. Okay, on to our readiness in terms of our provider network. So one of the things that we've already done is we've done a gap analysis to compare the current county LIHP program provider network to our plan provider network. And I'm happy to report that there is a high degree of overlap. We found, in fact, in LA County, there were only 5 providers in the county LIHP program that didn't have a Medi-Cal Managed Care contract in LA County. And so for those providers, we are collaborating with our county LIHP partner to reach out to those providers, inform them about how they can become a Medi-Cal Managed Care provider and help connect them to the appropriate group. Let's see, in terms of prospective network adequacy review, we are using our existing internal systems that we have in place to measure provider capacity as well as access and availability standards. We'll be doing our geo-access mapping to make sure, again, we do have and can demonstrate that we have adequate capacity. And in terms of provider outreach and training, that is a whole other area that will be given a lot of focus. As people mentioned earlier, providers are a key resource or a critical resource for members to get information about what is occurring with their healthcare coverage. And so we want to make sure that our providers are adequately prepared to answer all the key questions. And so we'll be putting together training materials, simple FAQs, and other materials that can be used for them to be able to support their current patients. And we are going to be looking at several training modalities, including webinars, as well as face-to-face trainings. So with that, I'm going to wrap it up and just let you know that we definitely think that this is a significant historical opportunity. We're lucky to be in a state such as California, where we have both the governor's administration and the legislature supportive of healthcare reform, and that is what's allowed this low-income health program to be established and allow for this bridge to reform to occur. So we're very excited to be a part of that and look forward to continue to jointly plan with our state and county partners to make it, again, a seamless process.
Thanks. Good afternoon, everyone. Does anybody need a stretch break? Because I won't be offended if you have to get up and move around a little bit. If you've been here sitting all day in a semi-dark room, I could totally understand why you'd need a little nap at this point. I'm Liz Gibboney with Partnership Health Plan of California, and I've got the enviable spot of being third in the row in the afternoon. I wanted to talk a little bit about what our health plan is doing with the LIHP transition, among a few other things. So my presentation today will just to give a brief bit of background on Partnership Health Plan of California, talk about member and provider outreach and network readiness, as well as initial health assessments and continuity of care provisions. So first, what is PHC? We're one of 6 county organized health systems in California. We currently have a service area that covers 6 counties in the Bay Area. We're going to be expanding, and I'll get to that in just a minute. We started in 1994 in 1 county with 1 program, and that was Medi-Cal. And we're a nonprofit, community-based health plan subject to the Brown Act. We're very locally governed with a diverse board members that meet every other month. The most important thing to know about Partnership is that all of our programs focus on low-income residents in the communities we serve, and that is what our mission reflects. We have lots of experience. Those of you who know us know that we like to expand into other counties, but we also have experience in developing other programs like Healthy Kids, as many, many counties did a number of years ago. We operate a special needs plan for dual eligible members in some of our counties, and that's been very successful as well. We actually worked with the CMSP folks a number of years ago in 2001 to develop a pilot program where we folded CMSP recipients in one of our counties into Medi-Cal and gave them Medi-Cal benefits. It was very successful. And we also have experience in moving to other counties. As I said, we started in Solano County in 1994. We have since expanded 5 times, and our 5th expansion is in just a couple of weeks, so we're pretty focused on that. So currently, our current stats are that we have 228,000 or so Medi-Cal recipients over our current 6 counties. The Medicare Special Needs DSNP plan that I mentioned has about 8,500 residents, 8,200 folks over 3 counties, and our Healthy Kids program is quite small, and that's in 4 of our counties with just about 1,200 kids. With the expansion that I'm going to talk about into the rural Northern California, we're adding 8 counties on September 1st, and we'll add about 115,000 Medi-Cal recipients to the health plan. So as we've all been experiencing over this last year, we have been focused on the Healthy Families Transition, of course, in a number of phases. and our membership numbers reflect that, that transition. As I mentioned, we're going to be going into 8 rural counties here on September 1st, and then, of course, the LIHP transition. And so all of these activities, I bring them up because they all play into one another in terms of member outreach and what we've learned both on the member side and the provider side and all of our transition experience. So sorry for those of you in the back, maybe even in the front, it's a little bit hard to see the map, but our current service area is the, I guess you'd call it purplish, the purplish counties. The top counties in Northern California plus Little Lake in the middle are the gray counties. So that will be our service area after September 1st. One of the strengths of the county organized health system is that we have a local presence, whether we're in 1 county or 14 counties. We currently have our main office in Fairfield, a small regional office in Santa Rosa, which is Sonoma County, and we're opening 2 regional offices in the north to accommodate our new growth, one in Eureka, which is Humboldt County, and one in Redding, which is Shasta County. And we think that even though it may be slightly more efficient to operate out of one location, it is certainly better for our community providers and the members to have a very significant local presence so that we're accessible to all of our constituencies. So first, even though we weren't necessarily asked to talk about member communications, it's a really key part of any transition, and LIHP is no exception. We've heard lots of discussion this morning already about the state notifications that are set to happen this fall, and we certainly support that. Ideally, in transitions like this, we would also prefer to send out a member notification welcoming the member to the health plan and asking them specifically to be in touch with us about what their current health care needs are, if they have any concerns, to make a primary care selection if they're confused about what their options are. In our system, a member can choose a PCP each month if they decide to. That doesn't typically happen, but that's open to them. We also do a fair amount of community outreach to our members and to stakeholders who work with our members. We tend to, well, I'll talk about it in a minute, but we have a monthly conference call during which we have a number of stakeholders call in, and we share information with one another, but we also raise issues and questions that we can then pose to the state or to the other agencies that might be of help to us. So with the member notifications that go out, and we don't anticipate that we'll be allowed to do that, say 30-day notice on our own or in addition to what the state's doing. At a minimum, we would be sending out new member packets, welcome packets in early January, and that would include an ID card, a member handbook, information on our case management programs, and a provider directory, encouraging the members or their families to give us a call with any questions. In terms of the community outreach specifically, which is so important in transitions like this, we have built a pretty strong network of community-based organizations that we work with to get the word out, because oftentimes members don't read the stuff we send them. So they tend to ask their providers or ask the county worker or a number of other places to get information about what's going on with their medical care. And so we also work with our local media to get the word out as well. Next, I want to talk a little bit about provider network outreach and readiness. We tend to be in touch with our providers quite a bit. Sometimes I think they feel stalked by us, but we intend with this transition to start monthly notices to our providers starting in September and October, and do it monthly going forward. We will also have our quarterly provider newsletter that goes out in October, which would include information about the transition. We also have our provider relations reps visit our PCP sites and specialist sites on a monthly basis, so they'll be reinforcing this message as they go out and physically meet in the provider offices. And then I also mentioned a bit ago the community planning call. We had what was really successful during the Healthy Families transition, all during the phases, a monthly call that was open to all the community-based organizations who were interested in signing up. That included providers and county workers and faith-based organizations, just calling in to either raise questions, things they were hearing in their communities, or to ask us questions that we could then pose to the state. And we intend to transition that as Healthy Families winds down. We're going to transition that to a LIHP oriented call and have the same format. And we are, it's open to anyone who cares to join. It's about an hour. If any of you are interested and are living in one of the counties that we serve or will be serving, let me know, and I'd be happy to put your name on that distribution list too. In terms of network readiness, we're doing the capacity analysis right now. I know we're supposed to be getting a file from the state in September that will show us the outliers of the differences in the provider networks between LIHP and our plans. But we're doing our own analysis right now on primary care to determine how much of an overlap there is. I suspect there's quite a bit, but we'll know that fairly soon. In terms of measuring capacity, we use the department standard primary care capacity of 1 to 2,000, one primary care physician to 2,000 Medi-Cal recipients, and for a mid-level practitioner, that's 1 to 1,000, obviously with medical oversight. And on specialist capacity, we have 15 or 16 high-volume specialties that we monitor and have ratios built that we know need to be contracted in order to accommodate our membership. As we move, though, into rural counties, we can't contract with a provider or a physician who isn't there. So we do our very best to provide care within the county, and when we can't, we provide transportation or resources, work with members and their families to get them to the nearest specialist that they need. As we've spent so many months and weeks traveling around in the service area up in the rural north, it's about 600-mile round trip starting from our Fairfield office, doing a loop around the north part of the state. One of the things many things we've learned about rural healthcare in the last few months, certainly there's a dearth of providers in some areas, and the rural providers are incredible and are incredibly resourceful at providing care with limited resources. So they've already done quite a bit, but they're also faced with very difficult transportation situations, small office staff, and in our particular case, they'll be going through the LIHP transition just 3 months after going through the main Medi-Cal Managed Care Transition. So while they'll know us very well, we've done extensive training in those counties, it's still all going to be still fairly new to them. So that is, I think, both an advantage and a disadvantage. On the initial health assessments, I think the two previous speakers covered it quite well. We are very adept at working with our provider network on initial health assessments, and we reinforce that with our PCP networks all the time. It's in our contracts, et cetera. With the LIHP transition, we were kind of anticipating we would have to go through the IHAs for the total population. So I think for there to be a slight reprieve if the member stays with their current PCP, that just makes it easier for those IHAs to be completed in time and for any action plans to be developed if there's some mitigating circumstances. And certainly we encourage all of our providers to get in touch with us if they need resources from us or care coordination assistance from us in addressing any issues that come up in the IHAs. So I think that's a pretty well-oiled process, at least within our networks. And finally, on continuity of care, we have a very focused continuity of care transition work group within our organization made up of all of our operational departments, any department that has direct interaction with a family or a family member who is on the partnership. We focus on about 15 different key populations, and this is one of the reasons why getting the data that you've heard mentioned so many times is so critical in order to ensure as smooth a transition as possible. Our committee tries to get data from a variety of sources to help the people in these different categories, including long-term care, California Children's Services, GHPP, people getting ready to go through a transplant, AIDS patients, people with long-term care if they have an open authorization for DME. I mean, you're getting the picture that these are what we think are the most critical populations that really need extra assistance during a transition. So our goal is, early identification of those members, identifying open authorizations, getting them loaded in our system, and having that transition go as smoothly as possible. In our health plan, most members are assigned to a primary care physician or a primary care site, but about 20 to 25% of our members are put into what we call special case management, and those are categories that allow for them to see any Medi-Cal provider who's willing to bill us and allows us to provide additional resources to them, and that's where we put CCS kids, transplants, hospice, ESRD, a whole variety of different clinical and administrative categories of members. And one of the issues that we're watching very closely is this very recent development about behavioral health and what the Medi-Cal Managed Care Plans are going to be responsible for. It was 2 or 3 lines in a budget that kind of landed on our laps a few weeks ago, and so we're watching and trying to decipher what exactly that means. Sarah's laughing. But it's something that we need to work very quickly on to prepare our current network for, and then to go out and find providers who are going to be able to provide the service. So we'd like to know as soon as possible what's included in that benefit package, and then we'll share it with our friends. So in conclusion, I feel like I'm kind of reiterating what's already been said, but I guess that's important, that communication is so key, not just to our members, but to our providers. We think our providers are going to be the front line of questions from patients. I mean, we'd love it if they call us, and they do, but they probably won't read as much as we'd like them to read about the programs. So I think providers are going to be the front line on questions and answers, hopefully. That's why we need to arm them with as much information as possible. And data. We need it early, we need it often, we need authorization data, claims data, utilization data, eligibility data. You all know the drill. And then, of course, resources and planning. Adding 34,000, at least we're adding 34,000 LIHP members in our service area, and we're so fortunate they're already in, they're all 14 counties are in the same program, so we think that will make it a little bit more streamlined. But, you know, we think that they're not just the average Medi-Cal client. They're not a bunch of, you know, healthy families, kids rolling over there, higher intensity, higher medical acuity. So we view the LIHP member is more like 2 to 3 times what a Medi-Cal recipient will require in terms of resources from our staff and from our providers, and costs certainly too, but we're looking at just how we plan for that. So those are the challenges that we're up against, and I look forward to answering your questions when we get to that point. Thank you.
Thank you very much to our panel members. I appreciate it. And now we're at that point for questions and answers. So if you're, we're going to open up the discussion for questions here in the room. We have about 20 minutes for that. For those folks that are on the webinar, please remember that you can submit your questions to the LIHP Transition Project at dhcs.ca.gov. Folks, if you'd like to ask questions of our panel members, please go to one of the 3 microphones here, and we will call on you and move forward there. Mic number 3, hello.
Hi there, RF Sheikh, Cal Optima, Coast Plan, Orange County. First of all, thanks to all the panelists. It was great to hear the different perspectives. Liz, I was interested to hear about what you were saying in regards to the communications and outreach strategy. You had mentioned you had some collaborations with local media. Mm-hmm. Would you mind elaborating on that a little bit? That seems like a really interesting angle.
Yes. I don't know if it's because of where we live and work, but the stuff we send seems to get in the papers, and we seem to get radio interviews. So we have a great media person, and maybe it's always slow news in our area. I don't know, but we have developed a really good media list, both in radio and print, and we try to be a resource to our local media about healthcare issues, and always be very responsive. And so they tend to call us when we send something out being new. And you know, reform is a major topic. I don't have to tell you that, in the last couple of years. And so